Good morning. Thank you for joining us for our monthly endovascular live case. We have a great case for you today. Today I'll be joined shortly by my partner, Dr. Raman Sharma. As you may be aware, we're currently experiencing a blizzard here in New York, so traffic is a little heavy. I will also be today moderating the virtual live session on the chat. So if you have any questions, please send them there. We look for a very interactive experience. Now we'll go to the lab with Dr. Krishna and team.
Yep, I'm going to let Dr. Kapoor do the intros this time.
Morning, everyone. Thank you, Dr. Krishnan, for letting me do the intro. So another exciting live case here from lab at Mount Sinai Hospital from the endovascular division, led by Dr. Krishnan. So, of course, everybody knows Dr. Krishnan on my left. We have Rain Laskan, or NP, on the extreme left, back in action. We have Awad here, one of the 3 endovascular fellows. We have Denise and Reka in the back to help us with the case. And then we have Damien and Freddie helping as the technician. So another interesting case, as always, a little bit challenged, thought-provoking, and we go from there.
So, yeah, no, great intro. You know, a little bit of a plug that I think we got to make is that, you know, we're NYEVS this year is going to be on September, I believe, 25th, 26th, 27th, if I'm right. David just checked that. And, you know, the interesting part I want to just welcome all of you is that the New York Endovascular Summit has continued to grow over the last few years. And, you know, we're in our 3rd year. So this year we're going to have, you know, 6 live cases. You know, we're coming from Japan and Tokyo with Dr. Tatsuya Nakama. And then we're going to go to Dr. Chris Metzger in Kingsport, Tennessee. And then after that, we're going to go down to Houma, Louisiana to Dr. Pradeep Nair. We're not going to do one out of Mount Sinai this year. It doesn't look like it. So on Saturday, we're going to go out to Italy, to Venice, to Dr. Marco Manzi, and then we're going to end up in Michigan with our good friend Dr. Nick Mawad. So we have a fantastic panel. I mean, obviously it's more a leadership of endovascular that's going to come. The other thing I want to talk a little bit about is that the Fellows course, the Endo Fellows course, is going to be on that Thursday, and then we're also going to have led by Dr. Guja, Dr. Sharma, and Dr. Song, and then we're going to have the industry-sponsored breakouts, which we call as therapy-based learning on that Thursday. So on that Thursday, when we have the therapy-based learning, we're going to have not only intravascular ultrasound and Phillips-oriented therapies. We're also going to do a gore and shockwave combination about vessel prep and management of these cases. And also, we're going to continue forward. As you know, Boston Scientific has done fantastic things in terms of purchasing great companies like Bolt Medical, and also they also are involved in the TCAR space as well. So it's a really full conference, and for the first time, we're going to introduce a new conference led by Dr. Aaron Murphy, Dr. George Croissant, and Dr. Rahul Patel, and it's going to be the Deep Venous and Pulmonary Embolism Summit, and that's going to be on Friday the whole day, concomitant with the Endovascular Summit. So it's going to be an incredible conference. Vishal, myself, Raman, David, and Karthik, and Ray, and everyone, welcome all of you to come. And I think we hope to see you guys there. It really is going to be, I think, probably one of the premier conferences very, very soon. I don't want to sound like Trump there, but it probably will be. but so without further ado, and sorry for that long-winded intro on NYEVS, we're going to go to our live case presentation with Dr. Javid.
All right. Yeah, play it.
Yeah. Okay, so we have a 63-year-old lady with the left greater than right lower extremity lifestyle limiting claudication that's progressed to ischemic rest pain despite maximal conservative therapy, including 12-week exercise program. Over the last 1 month, the patient has actually developed a left ankle ulcer, which I'll show you. As far as medical history, patient has a history of hypertension, hyperlipidemia, coronary artery disease, multiple PCI in the past. So in 2012, patient had left distal SFA stenting with an Everflex 6x80. In 2023, she had right proximal to distal SFA stenting, right proximal popliteal DCB, and right proximal AT stenting. Social history, she quit smoking in 2018 with a 20-pack year history, denies alcohol or other drug use. As far as medications, patients currently on aspirin, atorvastatin, clopidogrel, metoprolol, succinate. LVEF is 55% on the echo. Previous ABI in 2023 on the right was 0.26, the left was 0.72. This was an ultrasound done a couple of months ago, and it indicated severe stenosis, the anterior tibial, and then that's originally why she was brought in. So this was the diagnostic picture. So as you can see, there's a CTO in the left SFA at the ostium.
Yeah, so there was just to give you, between the interim time of presentation of the ultrasound and this, she definitely had progression of disease and worsening of the ulcer. Yeah. So that's the reason she was got into the lab, and we just anticipated focal ISR, but the disease progressed significantly, as you can see on the left side. And now we have a complete total occlusion all the way from the start of the SFA down into the popliteal segment. So that's why there's a little bit of mismatch between the ultrasound, but it's actually progression of disease.
Yeah.
And then we have better pictures here.
Yeah,
Why don't we go to our pictures? Michelle will talk about our pictures here.
Yeah.
All right.
So here you can, all right, let's go. Okay. So here you can see our pictures on the right side. The patient did have an intervention on the right done, just CKD, so we just took the groin shot, but you can see actually the stents that were placed in 2023 have become occlusive again. So we'll talk about the treatment strategy later on after this. But our goal right now is just to define and help with the ulcer, mainly on the left side with worsening symptoms. So
we can't hear you. Okay, our goal right now is to define the ulcers and how to help the symptoms. You can see that you have a snub of an SFA coming down with what looks like a moderate to severe calcified SFA. If you look at the PAX classification, then you have the SFA stent that's occluded distally, and then you can see that you have reconstitution of the above knee pop. Actually, you should say maybe about P2, P3 segment, and then you have very diseased popliteal, and then coming down with a short segment occlusion of the tibioperineal trunk into the anterior tibial artery. You can see there's a TPT that's occluded, and then AT is the dominant vessel down to the foot. So it looks like the TPT doesn't really reconstitute. When you look at the AT down to the foot, you can see that the AT comes in, and then you can see here as far as the flow into the ulcer, into the angiosome, the supplying the ulcer, extremely poor. You've got some retrograde filling of the AT that retrograde fills the perineal, and I guess that's probably going to be what's going to help. But I think the first step here would be to, if Raman and David agree, is probably to go ahead. We're definitely going to open up the SFA, and then we'll talk a little bit about infrapopliteal. So, having said that, any questions from the panel? Well, I just want to demonstrate what we're going to do so we can get started. Yeah. We're going to show the B-back catheter here. We just put an 014 wire, 018 wire down. We're going to use the B-back catheter to direct our thing, and Vishal will just show a little bit about it.
Right. So, hold on. Yeah, right there. Perfect. So this is a B-back catheter we're going to use for people who have not tried this before. So it's a very nicely set up hybrid catheter, which acts as a support catheter with directionality and able to re-enter as in how you would do with your re-entry devices, such as the Outback and the Pioneer. So it comes into two forms, 014 system, 018 system. We have an 018 system here and two shaft lengths, 80 centimeters and 120. We have a longer shaft length as used in peripheral. So the way it works is you can introduce your guiding wire in the back as a regular device. And then this is your support catheter right there, but this is where all the manipulation of the needle happens. So from a directionality perspective, you can change the direction of the needle firing base by rotating at the base right there. And the way it works is you have a knob right here, which let me show you So the knob right there, this is in the lock position. So if you want to slide, you can't slide your needle. So it's like a protective mechanism. So the needle is not going to come out from the tip. So what you do is you press your knob, the red pops out. So now the red pops out means you're ready to fire the needle. And if you see right here, it might be harder to see. You have two markers on this side. Let me see, it's just white on white. But right there. There are two markers right there, which shows you the length of the needle firing. The first marker, it goes 3 centimeters. and the distalmost marker is 7 centimeters. So you can actually control the amount of needle firing you want to do, in addition to the directionality by doing at the proximal segment. And if not need be, just use it purely as a wire catheter. So
Is
here
it 3 centimeters or 3 millimeters?
I'm sorry, 3 millimeters.
Yes,
my bad.
thank you.
My bad. So
Okay.
here you can see I fire, the needle comes out all the way. So it comes at the tip. It's a curved needle. And like I said, you can change the directionality based on this. So it's a very nice device, like I said, a hybrid of your support catheter, your re-entry catheter, in addition to directionality, and then hopefully getting to successful procedure.
Okay, so guys, we're just going to introduce it. You guys ask any questions you'd like. I know about bypass and any other options that were considered. Yeah, exactly.
Guys, so I guess we can blame Mother Nature, but sorry for the late arrival here. As always, we have another wonderful case. I would argue that usually in if you compare it to the contralateral limb, when you have a CTO segment that's fully covered in metal, the treatment now the treatment of that is,
go ahead.
is
pull the wire
somewhat
back?
a little bit simpler, just because of the fact you're as long as you begin within the actual vessel, within the actual walls of the stent, reaching the distal cap is going to be pretty simple. In this case, there is a real chance that once you get to that proximal stent, re-entering that stent may become quite a
now you need to fire the needle.
So
Ready?
I think
What's your
knowing
directionality? Go ahead, you do it.
inherent difficulty that you could potentially,
So go ahead, talk.
come into,
You want to
to use these adjunctive devices that have much more extra features than
try
just
the
a
wire?
stiff glide wire and with an angled
Nope.
catheter
Okay.
may actually
See if it
really
goes.
help you gear yourself for success and shorten the length of the case, minimize complications. I think this is a particularly nice device, mostly because of the fact that it has one major advantage over the Outback and the Pioneer, and that's because it's not a giant bulky straw that is being moved from the contralateral limb. So as far as trackability, this device is far superior.
Yeah, I mean, it's like Raman said, it's an end-hole device, so you can have the needle right at the end.
Here. Can you torque
Right,
it? Can
yeah.
you torque your needle? So you can see here, Vishal is trying to torque his needle, and it's not going any further than here. So what I'm going to do is you have the marker on the other side. As I'm torquing, the marker is changing. So it's now going to fire opposite to where my marker is to try to see now I'm in a better plane. You see how I redirected that away from the calcium where Vishal was going, and we were able to bounce it right into the main lumen. So I think Raman is right. I think that this catheter is phenomenal, as you can see. Flora, save that. It's phenomenal, and you saw how it slid down the proximal aspect. I mean, we really didn't dissect. I mean, it's very trackable, Raman, as you said. So now what I'm going to do, Raman, is I think we're inside the stent. The question is, that's where we're going to have to worry about IVUS. But let's talk a little bit about our algorithm here, because now we're luckily in the stent here. So the question, Raman, and David, our algorithm would bypass. I mean, we have best CLI, we have all these wonderful trials. What are your thoughts in this? And how would you guys approach it? Like, forget about that we're doing this endo because we have our reasons, because we're going to tell them to you in a second. But the question is, what about if this is your case in on a Friday or a Thursday, whenever you guys are operating, what are your thoughts? Let's walk it up.
Yeah, David, you want to start?
Well, like with the long segment calcified CTO like this,
right?
I do anticipate at some point you're going to have to place more stents in order to revascularize this patient. And given the patient's history, given, the anatomy that we're seeing, she may not be the best candidate to really have long-term patency with those stents. So I would definitely have a real discussion with this patient about percutaneous bypass as a feasible option for revascularization. That's part of my algorithm that I would talk with the patient about.
So David, just a question before Raman answers. I'm sure Raman's thinking this. Like, why PTAB before a traditional bypass?
So I would definitely have that discussion with the vascular surgery team here at Sinai. We have the luxury of having that working relationship with vascular surgery. But given, if I remember correctly, the history that Awad gave is that this patient has CAD, multiple PCIs. So there would be probably a prohibitive surgical risk, but obviously we would have to assess that. So that would be part of the discussion in terms of my algorithmic approach to this patient.
Yeah, I like the idea of incorporating PTAB into the contemporary patient.
Yeah, well,
I think a couple things to consider. There's all really great and valid points.
Right, slow pullback.
She's had single vessel runoff
Correct.
with a prior tibial intervention on this side as well.
No.
Is that accurate or no?
No, only on the right side. But yeah, you're right. There's a one vessel runoff.
Pull back. IVUS is going, guys.
The previous interventions were in the pre-Esprit era. And the original stent on the right, which failed, was a non-drug eluting stent.
Right.
Now, granted that they did, she did fail the Zilver of 2 years now, almost 3 years. She spent 5 of those years more than 5 years of those smoking, if I remember correctly.
Yeah.
So it's like, so she has reason for failure. I think that the PTAB is an excellent choice. I don't think that all of her endovascular options have been exhausted just yet, and that includes PTAB. I think just especially on this side, revascularizing one more time, but now ensuring you have adequate tibial outflow, and make sure we line them with the Esprits may really give her that increased patency that just treating the SFA with another Zilver or Illuvia may not really yield. I think that as part of my algorithm, I would assume as overall going about in the same direction here. The one thing that would kind of be a definitive part of this treatment would be to take a picture directly from the pop to see where is that PT, does it come back at all? You see a little hint and taste of it here.
Stop recording.
So I would like to, if possible, really try to open that PT up.
Totally agree. That's a great, all fantastic points. But let's ask Vishal, Raman, in this case. Yeah. Vishal, any surgical bypass options? Was a vein mapping done?
So we did the vein mapping. The patient has had previous GSV ablations done, so she doesn't have really good veins from her prior intervention, and because and that was the only reason which we discussed the patient with the option to say, okay, we'll give you one more try, and if it fails, then there's always a surgical option on the table.
And the surgical obviously is going to be a PTFE.
Yeah, that's where all the trick.
So before we talk about what we're going to do, let's look at the IVUS. Maybe we can play the IVUS. Mary's measuring, but that's fine. Let's just play the IVUS first.
But one more thing about the PTAB you're talking about. Remember the outflow vessel runoff on the trial.
Yeah.
Like one vessel you would not want to do it. Exactly.
No, PTAB, the outflow did not show any difference in patency with PTAB.
In the trials.
But the detour trial actually, it was not included in the excluded one vessel runoff. So we really don't know from the trial itself. I mean, of course, the forced follow-up, you've done a lot of them, so I'm sure experience is right there. But
what do you guys think with this IVUS now? So thrombus, no thrombus. What are your thoughts?
More of calcium with soft plaque.
So embolic risk, no embolic risk. Should we put a filter, not put a filter?
I mean, I'm just going to say the way how that catheter just glided down, even without any wire ahead of it. I mean, I think the gain has to be increased here, but I'll be really remiss to not suggest a filter in this case. I think that there's a very strong chance of.
So 018 Trailblazer, and let's open the EmboShield, guys.
And I think that's what you're right. Is explains the progression of the ultrasound showing focal stimulus on the left side, and suddenly you see a CTO in the last 3 months. So it's probably you're right.
It's somewhere.
Exactly.
And also this also demonstrates the power of IVUS. I mean, IVUS will, it can clearly show you that this is soft plaque and clearly something that can embolize downstream with single vessel runoff.
Right.
When the gain is high enough.
Yeah, when the gain is high enough. That's a good point. So what we're going to do is, it's actually, please, 018 Trailblazer, and let's get the EmboShield and the bare wire. So we're going to put the EmboShield down. Now let's use the IVUS now that you guys identified soft plaque with some calcium, not prohibitive calcium. So is there a role for thrombectomy, atherectomy, combination of the two or no? Because I like it with the fact that we have the IVUS now. Now we can make educated choices, right? So what are your thoughts on how you're going to prep this vessel? Because we know that the DCB likely failed because of recoil, and we know that the stent, I mean, obviously probably failed because of proximal progression of disease. So I'm just curious on what you guys would do in terms of prepping this vessel for the definitive therapy. So let's talk about vessel prep first. Would this be a shockwave case? Would this be a Rotarex case? Because we have a 7 French up and over, which I think is adequate, and then with the Embushil we can decide. So I guess the question is, well, what would your vessel prep choice be here, guys?
David, you want to go first?
So for me, looking at the IVUS, there are segments where there are definitely 3 quadrants of calcium. And we did talk about the wire behavior. So I would choose vessel prep to modify calcium. And I would combine this with some type of thrombectomy. In terms of Rotarex, that probably would not be my first choice. If anything, I would probably choose actually laser atherectomy. IVL is always a good combination as well if you want to combine that with another thrombectomy device. But honestly, I would probably go up front with laser here.
Good choice. What about you, Roman?
Yeah, I like laser actually, but I'll say that I think laser in and of itself is not going to take care of the thrombotic burden. And I actually like the idea of going with a Rotarex here as well.
I need a venous bag,
right? Because you're going to be getting
and a venous connection, a
good amount of like thrombotic particulate and plaque particulate with the aspirational thrombectomy and the entire treatment that the Rotarex provides. And plus, it's also very good in ISR. I think the one issue with the laser in this case, granted we have the filter down, the downstream embolization without some form of an aspirative thrombectomy treatment up front that could worsen the situation. Plus there's all that severe popliteal disease. So like I completely expect to not have any flow down to the foot as soon as we do our first adjunctive therapy. I mean, but that's an expected thing. So that's not going to really make me worry much. But I think that just to make this a little bit easier to consider to do some form of go straight with an aspiration, the thrombectomy device, or go with the Rotarex, and then an adjunctive dedicated atherectomy device. I think laser is an excellent choice. Or just see how the Rotarex does. I mean, it does technically do both.
Right.
Shockwave. I will say, I like it. I think it's overkill here.
Yeah, no, I agree with you. Go ahead, Vishal.
No, you're right. I mean, like PK said, the IVUS gave us a ton of information. There are islands of calcification, but not as, I mean, there is some significant, but like I said, it's islands of a calcification. It's not like tram track all the way up and down. So Raman is actually right. Using a shockwave might be an overkill. If we have areas or zones where we couldn't do a PTA after our initial atherectomy / thrombectomy of choice, then maybe, but probably like a plan B or a plan C in this case for sure. So yeah.
Yeah, to me, I agree with what. Oh, here we go. No, we get the issues here now. Damn it. Excuse my language.
The retrieval.
Jeez. As always.
This is going to be that little shake and bake.
Hopefully, right? Let me just see if I can get the wire back and go on the soft part of the wire and just slip it through. Doesn't look like it wants to go. All right, so let me push the wire down. Give me a balloon, guys. Give me like a 4-0 balloon.
Can I get a 4-0?
Yeah, pull the wire back.
40, 60.
Yeah.
40, 4-0. Give me a 64.
So flush this?
Yeah.
Yeah, I just thought we could slip it on the soft part of the wire, but it didn't work. So let me see. I just have to go with the balloon and push that forward.
And then push the balloon back.
So yeah, I think the laser makes the most sense to me. We got the new laser. Maybe you can put the camera on it. It's not the old Zamboni that we had in the past. So Freddie didn't have to drive it in, but it's much faster setup. Mary, what's the time for setup for this thing? So I'm gonna give you the exact information from our Philips people. What is it? 30 seconds, guys, to set up this laser. I mean, so this is compared to 3 minutes or 4 minutes or whatever it used to be. So yeah, so this is phenomenal. So what I'm going to do is just open the path for this thing to go down. So whatever reason it got up to that point, and this again demonstrated what Raman was saying about how slick that BBAC catheter is. It slipped right through here, while the Embushil did not. So you can see this. Yeah, 2.0 is that that'll go through a 7?
Yeah. 6. 2.0 goes through a 6.
What's bigger than a 2.0?
2.2.
Give me a 2.3. So we're going to go with the largest laser available, which is the 2.3. And then we're going to go ahead and, oh boy, look at this.
So see how the B back went in.
All right, give us a coronary balloon, guys. Give us a coronary 4-0. Walk it back. 4-0.
30. What are the biggest, longest you have?
So I know we're not through the stent because the B-back slipped right through. We just have that calcium in the front, Raman, that's killing us.
Yeah, you can always just go back with your trailblazer, get your wire all the way back down, and then run over that.
I think, we can't do a coronary. This is 0-4. We can't do a coronary. Okay. So yeah, connect the catheter. Let's set up the laser. We're running out of time, guys. Let's go. Vámonos. Vamos. My daughter always corrects me because I say vámonos and it's wrong. She says it's vamos. She said, Rafa said vamos, Dad. I said, oh my God.
We can connect.
No, actually, I think vámonos is actually correct.
Yeah,
You're just adding the pronoun. You're just adding the pronoun of we.
Oh, it is correct.
Yeah.
Okay. Yeah. Oh, okay. I didn't know that.
I don't know how well your daughter is doing in Spanish.
I know. That's actually a good point. I got to tell her. Oh, wait. If I say vamos, it's me. And if I say vámonos, it's
us,
we.
like we.
Oh, yeah. So I was talking about myself. And I said vámonos. And she said, no, it's vamos. I said, oh, okay. Huh? So she is
he wants a 2-3.
2-3. I want a 2-3. It's fine. We'll 2-3 laser.
Now, I think this is a good point to talk about the different sizes.
Can I have the balloon, guys?
Laser. You know, like at some point, the tibial intervention is going to be a part of this treatment, right? Considering the ulcer.
Balloon, guys?
Here, Ruther. You do this.
Go ahead,
I'm assuming that a tibial intervention is going to be a part of the treatment algorithm. You know, there's a lot of places in all the outpatient, the OBLs and the ASCs where you try to utilize the same laser device for both your suprapopliteal and your infrapopliteal disease. I mean, that's a way to do it, but I think we'll really miss on a real good opportunity to really treat the patient, because the amount of debulking that's going to happen with a 1.4 laser versus a 2.3 or 2 laser for the SFA pop is going to make the world of a difference. You could argue that with the smaller filter, the smaller laser, you'll have less downstream debris. You know, I think that certainly is a valid argument. But does that outweigh the utility of actually opening up an atherectomy device? You know, I would say that going with a 2.0 is like a 2.0 minimum. I think is an absolute necessity here. I think anything below that wouldn't treat your SFA pop at all.
Yeah, I think that's a very good point. Choosing the right kind and the right size of device is empirical in like having a successful outcomes. You're right. Sometimes you have to check
look at this. It's
viability.
No, let me see if the wire goes.
Oh, the wire is all tangled.
Wire's all tangled.
Yeah,
all right, let's take it out again. Give me a trailblazer now, and give me a new bare wire, guys.
Wait, did you just take out the entire wire?
Yeah, I had to because it got jammed. It got jammed.
Oh boy.
It'll be okay though. We should be able to cross. We did it once. We'll do it again. But
just take your go back and just push it right down.
Yeah, right down, exactly.
Can I get the Gladius? The Gladius, right? Oh, you want to start directly with the bear?
No Gladius.
Yeah, give me the Gladius.
Now, at some point, I think so we can have more discussion, because I think we can only talk about an SFA CTO so much. We should get a picture of the infrapopliteal and kind of make a decision as far as what the final treatment strategy really would be. I mentioned earlier that I like the idea of that PT being accessed, or not accessed, but opened up, and I'd like to see if there really is anything there that could be targeted for treatment. Because another option is that, if all else fails, would you send her for a direct tibial bypass? If this is such severe disease, and if you treat the popliteal this time, what if she comes back next?
And I think that's a great point, Robin, is what are you going to do when this fails? So let's talk a little bit about the available trials. So what I'm going to tell you guys, what we're going to do is lasers ready. We're going to get the ambush shield down. We're going to go ahead and start lasing, and we're going to have Awad talk about his presentation. Awad, go to your presentation while we set everything up.
Can we bring up the slides, please?
You can just leave us off screen for now. I already told the audience what we're going to do.
Where's my? Yeah, you calibrated her?
Not yet.
Here. Okay, let me know when you're ready. There. Want to calibrate?
All right, so we wanted to go over the best SFA trial and the sports trial
Give me
in terms of
the filter again.
SFA. Can someone
Ready?
hey, can someone fix my?
It's ready.
Okay, sorry. Can you hear me?
Laser ready.
Okay. So we're going to go over the best SFA trial and the sports trial in terms of SFA interventions. So starting with the best SFA trial, the objective was to compare a stent avoiding strategy with the stent preferred strategy, promoting optimal lesion preparation and the use of drug-eluting technologies in both arms. So it was actually a small study, 120 patients with symptomatic complex fem pop lesions. Rutherford Classification 2 to 4. The mean lesion length was 187 millimeters, and about 80% were total occlusions. So they were randomly assigned 1-to-1 to get endovascular treatment either with paclitaxel-coated balloon or polymer-coated paclitaxel-eluting stents. And lesion preparation, including plaque modification, was at the operator's discretion in both treatment arms. So the results, in the stent avoid group, the lesion preparation was more frequently performed, 71% versus 51%. But there was also a high provisional stenting rate, so almost half of the patients ended up getting stented. At 1-year follow-up, primary patency was 78% in the stent avoid strategy and about 78% in the stent preferred strategy. Freedom from major adverse events was 93% in the stent avoid group and 94% in the stent preferred group, no significant difference. So the conclusion, conclusion was that both endovascular strategies promoting lesion preparation before the use of drug-eluting devices suggested promising efficacy and safety results in complex FEMPOP procedures with the high proportion of total occlusions. So quickly, I wanted to go over the sports trial. The objective here was to compare angiographic and clinical outcomes of tax C and D SFA lesions after treatment with bare metal stenting versus drug-coated balloon versus the Illuvia drug-eluting stent. So they were randomized 1-to-1-to-1, 3 arms. The key inclusion criteria were SFA lesion length at least 130 millimeters and Rutherford 2 to 4, diameter stenosis greater than 70%. There were about 74 patients in each group, total of 224. So the baseline characteristics, the mean lesion length you can see was greater than 200 in each group. There was no significant difference in the number of CTOs. Is pretty high, greater than 70% in each group. And the reference vessel diameter was around 5. There was moderate to severe calcification in about 60%, 60 to 70% in each group. So what they found was that 1 year angiographic diameter stenosis, it was the best in the Illuvia drug-eluting stent. There was significant less in-lesion diameter stenosis at 1 year for Illuvia. DCB was non-inferior to bare metal stent in terms of diameter stenosis at 1 year. And then going out to 2 years, the primary patency data, so Illuvia drug-eluting stent was 75%, DCB strategy 52%, and bare metal stent 33%. Also to note, there was a pretty high rate of bailout stenting in the DCB arm, 58%. And then comparing 1 year late lumen loss is significantly better in the Illuvia drug-eluting stent group. As well, and there was a 2-year freedom from TLR was the best in the Illuvia drug-eluting stent group. So, you know, this was just a nice slide that I saw from recent talk from Gunnar Tep, when you're thinking about, based on current data, DCB versus drug-eluting stent. So, a greater lesion length will probably move you more towards stenting, a CTO, moderate to severe calcification, a higher task lesion, versus, you may think about the DCB in a Tachycardia B lesion, ISR, or no stent zones. And just keeping in mind that if you go with the DCB strategy, it may still be okay, but you'll have a higher bailout stent rate. All right?
All right, very good presentation. So Robin, David, what are your thoughts on the data? Because this obviously failed spot stenting, right? It failed it, and maybe Gunnar's right off 60-60. So now I just want to show you some of the techniques of lasering. So I think the key is the speed of your lasing. I think the key is you want to go ahead. You want to allow the vapor bubble to build in front, and then you want to allow that vapor bubble to do the work. If you go very fast with laser, you actually don't get a good job. You'd really have to allow that vapor bubble that forms in front of our laser to do it. Now, sometimes that can get very large. Patient can have pain. At that stage, you have to stop, and then you have to flush and then restart again. Within the stent, it's usually not a problem, but within the vessel, it can start to be a problem. So you can see here as we're coming in the stent, I'm going very, very slow, allowing it to work. He's feeling a little bit, but that's okay. I don't think he's a tough guy. He's going to be fine. We spoke to him. So you can see here as we're coming down, we're having a little bit of issue getting the laser down. So I'm going to just let it work slowly through this lesion here. A little bit of shimmy, and hopefully it'll work here. So there it goes. So now I'm going to go ahead and try to get through this part. And here is when we're kind of stuck here. It's not going. So let's go to 80-80 here, guys.
Yeah, I would just sit on it for a while.
Yeah, exactly. I'm going to try.
That's one of the beautiful things about laser is that it's especially useful in true CTO segments, like where you can't deliver any other adjunctive device. I mean, it really is a commitment to just the idea that even if there is no movement of the actual catheter, there is something happening at that proximal edge, with all the photoablation and thermal ablation that's coming by these vapor bubbles bursting. So there is change happening. So even if you just sit on it for a long time, 30, 60 seconds, this catheter will move forward.
Yeah, I hope so. Let's see. I'm going to try that right now. Raman on. So a little bit of forward pressure, not much, not really moving.
Yeah,
so
like 2-3 is a little bit bulky catheter as well, but you're right. The lesion probably is very tight right there. That precipitated the entire vessel to shut down. So I think that's
it's not going.
Yeah,
so I'm going to stop here, walk it out. Let's get the 4.0 balloon ready, and we're gonna take. Actually, just walk it out now. We'll do an IVUS before we take a picture. And then what we'll do is actually I'll balloon the distal and just take a quick IVUS. Actually, you know what? It might be smart to take a picture to see what the flow is.
Yeah.
We do have a little bit of a channel distally, and then we'll do an IVUS just to see well our filter is still down.
Did you guys? The filter went back down, right?
Oh, of course, yeah.
And it came back.
So let's do a quick DSA here, guys. After he comes out, it's coming.
It is.
Okay, good. You're
Starting
out.
with the entire device.
Yeah.
Ready?
It's stuck. It's so stiff to it.
DSA.
Yeah. Hold on. Wait, I have to flush first. I have all the flush in there. Give me 1 second.
Here you go. Here you go, Ray. It's burning. Ready?
Ready when you are.
Yeah, as expected, not much flow. Okay.
Yeah.
So let's go ahead and give us the balloon now. So what we could do, actually give me a twin pass. I'm going to put a twin pass down and inject within the catheter, but we'll do the IVUS first. I want to see what's within that.
What balloon is this?
There's a balloon? Okay.
This is a coronary balloon.
That's fine. We can do this.
I just want to make sure the line.
This will pass.
This is a 4.0.
Yeah, this will pass.
Yeah.
So we'll balloon that distal. Let's see here. Get a little channel going. We got our filter distal rail, please. Let's check out the filter. Oh, filters come back very proximal now.
Hold on.
So let's see. It's fine. At this stage, we're good. Where's the balloon? Right
Balloon's
there.
still not there.
That's the balloon, no?
No, no, we're still far away.
Yeah, you can open the twin
Still
pass.
far away. Not yet, not yet, not yet. There it comes.
No, it's not quite
Still
there.
not there.
Rail it for me.
Rail it is right.
Wow, look at that. The balloon's not going.
No, it's right there.
There you go. Now go
Right
up. Okay.
Give me the. Yeah.
So we're going to just balloon this and just push the filter forward. Uh-huh.
The the filter is full. That's probably playing a part in it.
Sorry. I doubt it.
Yeah, I think the lesion distally didn't open up.
Didn't
as we
open up at
expected
all,
it, so
yeah.
that's why there's
Down?
an outflow.
No, the balloon's not going.
You got to try to get your wire a little bit further. I mean, remember that P1, P2
Go up again.
segment was severely diseased
Yeah.
as well. You know, this is a doozy of a case.
12, 14.
You know,
Yeah.
again, you know, as you
Yeah.
said earlier, you know, like, even after the atherectomy was performed, it's completely expected to not see anything.
Correct.
You know, especially in this case where there's just so much distal disease as well. If you can get your filter just like just like nub it down, hopefully
Go up here.
maybe you'll be able to see a little bit more.
Yeah, this is very diseased. I mean, Raman's right. 18, 20. Down. So now I'm just going to keep nubbing this filter down. Let's see.
There it comes back.
Wow. Okay, walk this out, guys.
Hold on.
It's not going. So give us a coronary balloon, please.
I think actually what's happened is that your filter is what's causing you trouble. You know,
Yeah.
No,
there's a severe lesion at 30. You
Right.
saw the filter open up and then
Yeah.
come
And then
narrow
come
again. So I think the problem is that there is that severe lesion right at about 30 here,
Have a
which is
four
kind
up
of
there.
preventing that filter from just popping forward.
Right.
Mm-hmm.
I think we've
Agreed.
opened up that P1 segment pretty nicely.
Let's see. Let's see. Those. I like having the filter there.
Yeah.
Let's just
You
see
want a
what we
4030 coronary?
4030 coronary. I'm just gonna put. There's a new one.
No, it's not new.
I
Here's
don't
a-
understand. I
another
don't understand why
question.
we're trying to save money in a live case, please. You know.
Oh boy.
So I mean, I'm just saying. You know, it's not going to go. I mean, so it's like, why are we trying?
Yeah.
Let's go ahead and get it done. So we have any questions from the audience on this case or comments?
I got one for you.
Yes,
so,
please.
So I noticed we were talking about, you know, we talked about IVUS, the fact that this progressed so quickly from just a velocity of 300 and change to a complete long segment CTO. The idea was everything that there's some concept of, you know, some underlying presence of some thrombus here. At what point would you guys now say, hey, look, we've done a pretty significant amount of laser
Back it up,
atherectomy
guys.
here.
Yeah.
Should we proceed with a thrombectomy device now?
Well, that's why I asked for the twin pass, Raman. And I think the twin pass will really help us to see whether we can do this or not with a thrombectomy
there.
device. Okay,
Yeah,
go
right
up here.
distally. Okay.
Go up here. So I think a thrombectomy device will definitely help us, you know, with the twin pass. When we inject with the twin pass, we're going to see whether we have any clots or any crud sitting there, and then we'll take it from there. Okay, down. So we did get it this far. Let me just pull back here, go up here again.
I think it's just problem with the outflow and the
Down.
calcification eccentricity right there,
Yeah.
which is just causing all the trouble.
Show me down now.
I mean, there's definitely disease just
No,
down,
no.
like Raman pointed, another P2 segment.
Show me down now.
Yeah, show you down. Yeah. See, and see how that's where we had deployed this filter initially, and then see how it's.
Yeah, the little knuckle there.
Yeah, it's not going anywhere. So I think now we have to take the twin pass down. Give me the twin pass, guys. And this is just a technique that we use here just to see what we're dealing with. So the twin pass is like coronary a catheter that has a dual lumen to see whether or not you can actually, you can inject and see whether you have, you know, in the true plane or the false plane. But in the peripheral, I think it allows us to see what's in the vessel along with IVUS. But I think the twin pass is in my opinion, with thrombus is quite good because you can actually see the thrombus quite well. So it's a monorail catheter with an end hole. So
this is not
the twin
It's
pass.
not a twin pass.
What is this?
That's just a balloon.
There's not a twin
No,
pass.
there's not a
It's
twin
just a
pass.
microcatheter.
There's a microcatheter. They gave me a
I'm like, where's the wire
microcatheter.
coming out?
So I guess we're going to go with the twin pass. So it just allows you to see a little bit better.
Yeah.
So
It's a very creative way to use the device. Traditionally the TwinPass is used in like STEMIs and trying to deliver peripheral vasodilators, but in purposely injecting it with contrast then allows you to have direct visualization of whatever the material that's where that second side hole is currently in. There are some people who actually use a similar technique in helping cross atherosclerotic CTOs, both in the coronary and peripheral literature. With the idea that the contrast acts as almost like a lubricant and can help a hydrophilic wire pass through the little microfenestrations within a CTO segment. This is obviously not that case, but it's an interesting way to use the devices used, throughout our all of our treatments that we have.
So there you got some flow there. The filter is not full, which is good. So now we're going to pull back a little. Show me above.
There's stasis.
Yeah.
Let's inject here. So we got a big goober sitting right there, looks like. Show me above.
And you can see that too, because even if you go back down to where that filter was, it looked like that the contrast was still hanging there. So there's stuff inside the filter, there's stuff outside the filter. I mean, there's
no mueva.
A lot of stuff.
Relax.
Okay, looks like there's a lot of stuff going on down there. So yeah, there's no flow. So I think we have to do a thrombectomy now. So yeah, there's flow, but it's just not good flow. It's just hang up. So let's get a LeBron catheter, a 7.0 LeBron. So the question is, Raman, I think we'll run the IVUS now, then start with the LeBron, or should we just
skip the IVUS?
Skip the IVUS. I mean, we have time while they set up the LeBron. So what we'll do is we'll just run the IVUS just to get an idea of what's going on, and then we'll set up the LeBron, and then we'll take it from there.
It's 8:48. So
don't worry, we'll get
pressure, right?
No pressure. I mean, this is a complicated case, as we know. So what we're going to do is we're just going to run this IVUS to see what's going on. Flush the device, guys. Yep. So I'm going to flush it just to flush everything down. Keep flushing. Okay.
Right, can we increase the gain a little bit, please?
Okay, LeBron,
65. Give me 55. Yeah, 60.
Give me 6.
Give me 60 all the way.
Okay, let's go.
Perfect.
Record. So I'm going to record this.
Get the IVUS on the screen, please.
Yep, record.
Outstanding.
A lot of plaque.
Yeah.
Not as much thrombus. We did a pretty good job. Got a nice little lumen. Nice little lumen going there. So we definitely have a lot of.
Right there. A little
Ray,
bit.
can you set up, please?
Ray, come.
I mean, the other possibility is that this could all just be because the filter is it's already narrow because you're in a disease segment and you have a lot of debris down inside there. I mean, that in and of itself could take care of it. That could be the reason why. I mean, a cavalier person, may say, "Hey, look, that's what I think it is. Let's just take the filter out. Let's see what happens." I'm not sure whether that's what we want to do right now.
No, I think you're absolutely right. I think we got to go in, suck out the overlying clot.
Yeah.
So Ray, can you talk a little bit about the LeBron and how it's set up?
You have to talk.
Okay. Oh, you can't talk right now. Can you talk? So obviously, so I'm the only one who knows how the LeBron is set up. So it's basically a flush catheter with a dilator. So you can see Raman in my hands, the dilator is out front, and then it goes in the back. So it's a very flexible tip. So because of this very flexible tip, it's like almost like the 6 French penumbra, the new device that's able to come down. The 8 French comes with this separator that you can use. The 6 French also comes with one, but generally speaking, we go in without the separator. Can we have the LeBron kit, guys, so we can put it together? So we're going to attach the catheter to this end, and then we'll go ahead and aspirate and flush the system. Once we flush the system, it has a novel way of knowing when you're in clot and when you're in blood. So when you're in clot, it actually will aggressively suck, and when you're in blood, it'll actually stop, and it'll tell you by this beeping. So I don't know, do we have the stuff or we don't have the stuff? So it's coming. Okay, so we're gonna hook this up. So we're flushing everything. So at this stage, I think the iris showed that we have crud, and we're going to have to do this LeBron before we do anything. So I'm just waiting on the devices. So let's talk a little bit about best CLI, Raman. Has that and David and Vishal, has that really changed your practice quite a bit?
Yeah, I would say so. I would say in the sense where if the first comer, I would say perhaps not. I think the conversation ends up being the same. Unfortunately, you offer a patient an open surgery versus an endovascular approach. It's very hard that the patient themselves would opt up front to go for an open surgery. It just sounds like more of a pretty consistent patient preference just across the board. But when you start to have these repeat, frequent flyers, they have 2, 3, 4 interventions on the same side. Assuming that you've not also ablated all the veins, and there are some GSVs, some venous conduits that are appropriate, I find myself thinking that perhaps this is a much more aggressive conversation to have with them to say, hey, look, there's only so many times that I can go back in, even though in reality you can go back in nearly an infinite amount of times. But you don't really want to, because at some point you want to get a durable option. Because we do have the treatments that have patency up to 5 years of 70%, 72%, which is still excellent, I think addressing all the modifiable risk factors, smoking, diabetes, high blood pressure, high cholesterol, having them really participate in an exercise therapy, these are things that have meaningful impacts in the long-term patency. But I think up front, although that there is reasonable data to show without really much debate that a venous conduit for a long FemPop CTO.
All right, can we open the penumbra?
Is a
open
good,
the penumbra.
It's a good treatment algorithm. Yeah. I think the decision that ultimately lies on the patient as far as whether they want to have an open bypass surgery versus an endovascular first approach. I think that's just the end of that.
I think that's a great point. I mean, just the whole spectrum of surgical intervention, endovascular intervention. I guess it's probably just patient-oriented presentation, like you rightly said, repeat offenders versus first time. And I think the advent of this newer technology of the BRS, the bioresorbable scaffolds, does change the whole way we look at disease, especially in below the knee, because most of these patients, like you said, present with multi-level disease. So you have an SFA POP disease and you have below the level disease. Most of the trials which happened, we can talk about one trial versus the other, more the inclusion-exclusion criteria and surgical perspective endo. But now with the Esprit scaffolds, I think that's also been a game changer in management of these patients more aggressively with better known long-term outcomes now with the 3-year data showing good patency results. So I think that also adds on to the mix and probably makes things more complicated, I would say, rather than easier sometimes to say, should I try one more time and this time maybe give it a shot for the scaffold, and if it works, great. If not, then surgery versus direct surgery as well with the outflow. So I think it's like you said, it's a
very nuanced conversation. I mean, I think the problem is that very few patients are best CLI patients. Very few patients are any typical trial patient.
Turn it on, Dave.
It's and that's a little bit of a headache, that the patients don't follow the textbook, but at the end of the day, that's kind of what we do. It's a little bit of an art, I think there's some people who are very, very successful at keeping their patients away from surgery, and on the other end, some people are very successful at keeping the patients to go for surgery. And I think that there's some technical difficulties happening on your end, but
well, the problem is that the catheter wasn't in the room, and now they're setting it up. It's not really technical. It's just a question of just getting the catheter set up and then starting it. So yeah, we got the catheter now, and it's now going to start. We're just prepping. So the LeBron, once it's flushed, we can go ahead and start.
For you, would you say best CLI has changed your approach for
I think these patients. I think you're absolutely right, Raman. It's very nuanced and it's patient oriented. Yes, but I think. Are we ready, Mary? We can go.
I'm going to take the dilator out.
Yeah, not yet. We got to go in first.
Where?
Yep. Okay, ready?
Yeah.
Stop. So I think that for me, Raman, I think any CLTI patient, I get a surgical consult now, because I think that with a true CLTI like this, with an ulcer in the Achilles tendon, I think you definitely have to have a surgeon on board just to make sure that you don't have any options with surgery. In this case, it's more clear cut. You don't seem to have any options with surgery, so I think we're going to go forward with this. Obviously, the risk of this procedure is very high. You have so many things that can happen, like embolization, and as an operator outside, you have to make sure you have the right equipment. Yes, it took us a little time to set up the LeBron, but we have it. Yes, we have a penumbra in house. We could have done with a penumbra. The point is that there are multiple tools. Dilator out. Yeah. There are multiple tools that you can use to be able to do these procedures. So once we walk this dilator out, we're going to start this device. It's a very soft device. It really does track well. It has a very rudimentary on-off switch that Ray will demonstrate by turning it on and off. And we're going to go ahead and suck everything out. I don't have the wire.
Okay, I'm going to pull.
So, okay, now turn.
Yeah, and if you look at the machine right here, I mean, they have the suction power up there and the sensor, which is where you can actually sense, and it makes the noise of whether
it's it sucking, guys, or no?
No, yeah. Hold on. It's all the way to 30. Hold on. It is.
All right. Ready to go.
It's on.
It's on?
Yeah, but nothing's coming out.
No, but it's not.
Yeah, very slowly, though.
It's coming.
You have to close the TUI, so it's
Yeah,
not
it is
there.
closed. It is closed.
Yeah, of course, TUI's closed, yeah.
It's just, I think it's sitting right in the occlusion. So
yeah, but it's not making any noise, though.
Yeah.
Doctor, there's no sound. That means
You're
you
in.
could clot. Something you want to maybe flush the catheter, try to get it out.
Yeah, well, we're going to have to flush the catheter, but I think that the question is, you can see at this space it's not. So the problem with this now is we have the two devices, so we can use the dilator to push the clot out.
Yeah.
Use the dilator, guys, because we have the filter down too, which is another problem. Yeah. So the other thing we could do, Raman, is just balloon the whole segment.
I don't have the wire.
Yeah, and then take a picture.
That,
yeah, and then take a picture.
No, because I mean, you don't have like thrombus backed up all the way over there that's preventing the passage of a catheter. I mean, this is just tight disease.
Correct.
I think a long 4-0 balloon, 5-0 balloon, plaster whatever is there against the wall. You have a filter. You're not going to see anything probably. But I mean, it's very quick to assume that these lesions are straightforward. But as expected, I mean, this is full of a lot of very complex material here. I think that's why this is such a challenge.
Can I take out the dilator again? No, just cross that area, which I think is maybe calcium. Take out the dilator. So now we're going to try to go back with the LeBron. Yeah. Get a 4-0 long, Freddie.
Or I'm going to turn it on once he's on.
Got it off to the patient.
Yeah.
And let's see if we can get a couple runs of this, and then we can get a picture, and then we can talk about what the final plans are as we're approaching 8:59 now.
So we're definitely in clot. There's no sound.
Yeah.
Okay, walk it out. So walk it out under suction. Give us a 4-0 long, Freddie.
So we didn't get
under suction.
So yeah, we're not able to push it forward. So I think again, there's another thing, Raman. I think these thrombectomy catheters are good and everything, but you can see that I think you still need a lumen to get them to pass.
Yeah, that's why honestly I like usually in these cases to go, especially if there's a stent involved, to go with a more aggressive debulking agent with either a directional system or with the rotational atherectomy with the Rotarex. I mean, it just my personal preference, and I've always seemed to have more success with that. So have an initial run with like a Rotarex, and then decide what I need next. Do we need another atherectomy system that is going to debulk a little bit more? Do we need another thrombectomy system that's going to aspirate more?
But I think that becomes prohibitively costly. I think that the idea here, I think we did the right thing by going with one atherectomy system. I think we thought we had enough lumen to go ahead and balloon, but we obviously didn't. So I think now, to go ahead and thrombectomize. So I think we have to balloon with the filter down and then decide how we're doing. So you can see the balloon is going without a problem, right? Filter came back as we expected it would,
It wasn't me
because we were pushing the LeBron quite aggressively.
Yeah.
So let's go up here with the balloon. So we're just going to go up with the balloon here. We're going to try to open this system, and then we're going to take a picture. I mean, you're right. We're probably not going to see much, but we still have the filter there, so I'm not too worried. So there goes the balloon now. See, there's a look at that tight lesion there. So we're going to go up to like 20 atmospheres with a 4.0.
Yeah.
Okay, good, down. So then low mag here, guys. And then I'm going to come back here. Again, you can see the level of calcium in this case. It's just a very difficult case. Okay, go up. 20.
Yeah, it's like a mixed morphology
20.
case. A lot of plaque, a little bit thrombus, some calcium.
Okay, down. So now, let's see where we are.
It just goes to show how we thought that crossing would be a biggest limiting factor, but I think post-crossing is what's the real decision making there. Right
20.
there. Look at the eccentricity
Down.
of the.
And then a little dye just to see what my osteum is. Uh-huh.
Don't flash. Hold on.
Uh-huh. Okay, wait, hold on. Okay, go up there. 20 atmospheres. 20. Okay, down. Walk it up. So I'm just going to now walk this out and take a picture. Let the balloon come down before you pull, please. So we're going to take a picture now, and then if we don't have much thrombus, which I think we're going to have quite a bit, we're going to have to go back in with the LeBron. So let's see how this does.
Now, I think one thing that Vishal is doing that is very good is being patient. Because if there is the idea that there's a lot of a clot here, if you just yank that balloon out, it's going to toothpaste all that, whatever that may be there into that profunda.
Yeah, you're so right.
And that would be, make a bad
really
situation worse.
A really interesting live case. Okay.
Yeah.
So I guess that's why they tune in, right? So let's do a DS. Let's do a DSA.
Next month and see you guys still working on it.
All right, DSA guys.
Okay.
Ready?
Yeah. Let's see.
It should be flowing now.
I hope. Not quite yet.
Yeah. Let me just go for a dry run and see where on a coronary mode and see where exactly.
There it comes. I think. See, here it comes. It's just. I think the outflow.
Yeah. It's so
our filter.
Maybe it's just the filter.
Filter's full. Yeah.
Well, there's some flow after it, but the filter is full. You're right.
The filter's full. You can see the clot right there. All right, give us the LeBron. We'll go capture the filter if it goes.
Yeah.
We'll just capture the filter now.
Let's flush this, LeBron, please.
So it's done. It's ready. Oh yeah, go with the dilator.
Right. Let's
Is it
capture
really?
Says we're approaching 903.
Is this suctioning?
What we should do is that let's plan to remove the filter, take our pictures of the system.
we're gonna stay live here,
Yeah.
Raman. So what we're gonna do is we're gonna finish up. I think that at this stage, what we're gonna do is, I know you probably have clinic and stuff, so if you want to go, you go.
Yeah,
and what we're gonna do is, if David, if you can stay, we'll finish up.
I don't have to dial it
It's fine. We'll finish up, and then because I do want to show them how we handle this, because it's a very difficult situation when you have this kind of clot and this kind of flow. So one of the things we do is we go with the LeBron. We're going without a dilator now because we've been able to dilate it well. Hopefully it'll pass. So obviously I'm just showing Vishal the filter, because up top, if it goes, I'm going to feel resistance, which I feel now.
Yeah.
So again, the same spot where where the LeBron was having trouble, it's having trouble again. So we're going to need a dilator here, guys. So this is calcium. So we're going to put the dilator on.
Put the dilator.
And then we're going to go. So turn it on. Actually, don't turn it on yet. No, it's not going to. I think that this catheter is just not trackable. It's not going to track because of this calcium. So I think we're going to have to capture this filter.
Yeah, no, we don't have wire. I mean, it's just, you'll get the wires.
It's a 6 French, so if we had gotten with an 8, it would have been even more difficult. There's nothing stuck there other than the calcium, and we expanded with a 4mm balloon, and it's still not going. So, Ray, can you rail, please? I don't.
Yeah, wire should be.
The wire is very important here.
Yeah, it gets tight as soon as it goes. Okay, so we're. Okay.
Yeah, there's a dilator, so I'm going to push it through now.
Yeah, I'm going to put
See,
it.
with the dilator, it goes. Okay, now take out the dilator.
Okay. Here, Ray, walk it out. I'm going to hold the catheter.
And now we're going to go on with the LeBron again. Hopefully it continues to go forward. Problem is you're not going to have much flow because of that proximal lesion, I think. So, which is another problem because we can put it on that hyperdrive mode, which will suck out more of the disease. Okay.
Hold on.
Turn it on, guys.
Yeah.
Turn it on.
Yeah.
Uh-huh.
On.
Okay.
Okay.
So we're in
So now
something here. So when you hear that clicking noise, means it's in clot, right? So we're just going to allow it to work a little
Yeah, we're
bit
engaged in the
and just move it slightly forward. Try to get as much of it out as we can. So we're clicking and hopefully try as long as it's working. I'm just going to allow it to work. You can see that it's not sucking out as much blood, and it's really trying to get the clot. Looks like we got the clot there. We got some clot coming back, so now we're just going to go forward again. And you can see that proximal area is going to be an issue for us. So here there's no clot, right? No clot here?
No.
Are we engaged here?
Now we are.
Now you're engaged.
Now we're engaged, so I'm letting it work again.
There is something in the catheter, I believe.
There is something in the catheter.
You want to take it out, flush it quickly?
It's another major issue with these things. You know, you always have this something in the catheter. Do I have to? Can you put it on hyper mode? You know, it's like you have no device, especially when you have a filter in. You have no device that's really going to help you to clean this catheter.
Boost mode.
It's working or no? So it has a boost mode.
Okay.
You want to flush the catheter?
I need a slack. Slack. Well, we're almost there, so.
I won't go through the filter. Work it out. All right, so LeBron is not working in this case for sure. So we're just going to keep it on and come out slowly. Get me a multi-purpose guide ray. I want to capture this filter. So the other thing you can do is put a multi-purpose guide down and then try to capture the filter. So one of the tricks you can do is now we have the multi-purpose guide. So, you know, these thrombectomy catheters are great, but, you know, I think they're not really meant for these kind of lesions. I don't care whether it's LeBron or the other one, the penumbra. You know, these kind of lesions are very difficult. So I think, yeah, if you have fresh clot, I think it works really well. But in this kind of chronic thrombus, I think, you know, the atherectomy works well. You know, it's fine. Let it bleed a little bit.
You want to put it on this aspiration?
Yeah, let's see. Let's get it down there first. It's going to be a pain in the neck to get it down there. So let's see how it goes.
This copilot here.
Okay, it's going so far. So now we're going to use an 035 wire, guys.
You mean 035?
What? Wait, it may go. Yep, it went. Show me down. So you see how the catheter now goes down. Now give me a co-pilot, guys.
I am.
You have it right there.
It's okay. Yeah. All right, turn it on. Don't.
No, I don't want to put this catheter on. You think it'll?
Just
Oh,
negative
with this.
suction.
Okay,
Just
let's
use
see.
the suction.
Yeah, I don't know if it'll work. We'll see.
Whatever, something is better.
Okay.
All right, just turn it.
Turn
The
it on.
suction on. Yeah, see. Hold on. Turn it under. You pull your wire. Do whatever you got to do now. Yeah, just pull the thing out.
So it's engaging.
Engaging.
See. Come here.
There's something. I think there's something stuck in the catheter.
Yeah, it's the filter. So what I'm going to do is I normally inject, but Vishal just wants to pull it out.
Yeah.
So I think we'll just pull it out under direct suction here.
Correct.
So like that, and then what I'm going to do is just take the whole system out. So now give me some dye, guys. Another wire.
Yeah.
Give me another wire. Turn off the venous flow, guys, for me.
You know the.
So give me a command wire now.
Give me a command wire, please. Give me the.
So now we're able to get most of it out. The question is now, what's the flow situation? So we're going to put a command wire down. I think that one of the things that we talk about in theory a lot, I think, is about the these thrombectomy devices in these type of lesions, I'm starting to believe more and more there's really no role for them unless you have fresh clot. Because, if you have these really tough goobers, they really don't come out with these devices. We've tried them multiple times. I think the idea maybe lytics, early lytics may actually help. And I know I'm sounding like a dinosaur going backwards here, but the reality is that, when you do enough of these cases, you just know that it's just not going to work. And, in this case, I think Rotarex or laser was the right choice. But then after that is the situation of what you're going to do, So right now, okay, we're at this level. If I can lose my loop here, which I'm not going to be able to, unfortunately. Okay, we'll leave it here for now. Now let's take a picture.
Okay.
Let's take a quick picture, see what we have. We might have to put a 4.0 balloon down. Ready? Go. Give me another 4.0 long balloon, guys. No flow. There's no flow.
Let me increase the...
Here it comes, a little bit. Yep, there's flow, just very poor flow at the distal because of the pop. Okay, 4.0 long balloon.
You want to see proximally what's going on?
Yeah.
Because we haven't, the lesion is all proximal. Yeah.
Mm-hmm. No, it's good. Good flow.
Yeah. Good.
So we've got a good lumen now. It just might got to now fix everything.
Right.
Our outflow. So we're going to open a 4.0 long. We're going to balloon this, and then now we're going to go ahead, get our wire into the anterior tibial artery, and probably make sure there's no outflow issues in the anterior tibial artery. And then we'll decide on our final therapy. Question is, David, what do you think about the popliteal? I know you love PTAB, you do a lot of PTAB. The question is, are you worried about that anterior tibial artery, or that popliteal if we put a stent there on how we're going to deal with it? Without good outflow, this whatever we do here is not going to stay open. So my worry is, what are we going to do with that?
So looking at the previous, the most recent angio you took, it looks like the P2, P3 looks dissected to me.
Where's my balloon?
So in this particular situation, I think you have to stent. You're committed to stenting, especially since the outflow is not the best right now. Unfortunately, that may compromise PTAB down the line as an option, but for now, if we want to complete this revascularization, I personally would stent that P2 section. I think you can stent the P2 section without compromising the AT, but I would definitely, once the SFA pop is revascularized, consider some aspirins in that AT to ensure that the patency remains there as well.
Yeah, I agree. Just trying to see what's going on here to get this down.
Maybe get a picture.
Yeah. Give me a run through wire here, guys. Give me a run through. Yep. Run through 300.
Okay, hold this. Keep the connect.
So I'm going to wire this to ensure that I'm in a good lumen, and then decide from there what to do. So the run through wire is going to go down now, and give me the shaper.
Yeah, probably in this case, after so much work, we probably just take care of the AT and inflow, and then might, with the creatinine and all the issues, might have to bring her back to do that PT segment that Raman talked about to give it a better flow for sure. So that's one thing. Wow.
Do you guys think you need to stent the pop? It looks kind of dissected, no?
I don't know. We'll take some better pictures, but right now, yeah. So there's a lesion right there in the AT as well.
And the wound is at the heel, so you would prefer to stage that PT intervention, or?
I don't know.
Yeah, with the creatinine and
the creatinine
and the time,
like
we're already
2.1.
giving too much dye than we wanted to. All right, let's go up here.
Yeah.
So we're going to go up with a 4.0.
Yeah, the question is, we haven't fixed the left popliteal, or no intervention done on the left popliteal
There's
previously.
the lesion right there.
So the question really is, do you want to just DCB this, or you want to stent all the way up and down to the osteum, or just DCB
If you believe Gunnar's trial, then you know you got a stent. So the question is, you want to DCB the pop and then stent? The question is, how does it look after a balloon angioplasty? And I think we do an undersized balloon angioplasty. Mary, what was the size of our popliteal?
Popliteal size.
Yep.
Yeah, or probably just DCB, leave it de novo in case needs. Probably come back for a bypass or a PTAB, like we talked about. But once we stent, now our options are really.
But
limited
even
in
with PTAB down the line, if that P2 or P3 is disease, you still have to treat it. So you may still have to stent
20.
it when you come back for PTAB if it's
Yeah.
not perfect.
It's better to send it then than now and then burn your
fair.
bridge.
20.
But again, like I said, these are all conversations like you talked about.
Down. Little die, show me the
Yes.
oscar. Hold on. Go up here.
Yeah.
20 atmospheres.
20 it is.
Down.
What's the vessel size
Down.
for the distal pop?
5.
5 off? Yeah,
Down.
5.
Raise there.
Yeah, right.
Okay. Good DSA. Oh, let's go down to the pop. Low mag.
Yeah.
Good DSA.
PSA it is. Come on.
Yep, there's the AT lesion. So give us a 3-0 long balloon guys in the AT.
Yeah, that's where the dissection of the AT is. There's really no
Well, it's not
outflow.
really a dissection. It's just probably maybe the
disease.
filter dissected it, but we had to treat that anyway. So get us a 3-0 long balloon, 3-0 120 or 3-0 150. What do you got?
120.
You don't want to cut it.
No, I'm going to spray it. So now we got to ensure our outflow. So now we're going to go ahead and balloon this and spray this. So IVUS wise, what was the AT IVUS? We didn't go into the AT,
We didn't go into the
but it's probably like a 3375. So let's do this now. What was the repeat creatinine from the lab? Real?
It was,
Mag it up, guys.
yes.
Okay.
Hold on. One second. Go.
The wire came all the way back, Vishal.
Oh, it got stuck at that.
Okay.
Good.
Okay, let's go up here. Mm-hmm.
4,
So there's a real lesion in the AT there. Look at that.
6,
8,
8.
10. Okay.
Looks like
Save that,
the
guys.
lady, maybe no more than a 3.5.
No, I think 3-0. There's a 3. Oh, you're 10. So
Yes.
3.35, 38 is free is fine.
Yeah. Can I get a look for a 3.5, 38 Esprit?
Down. Okay.
Yeah, I think it's like I said, it's all the outflow.
Okay, inject.
Yeah, injecting. Much better flow. That's a 3.5.
No, it's not going.
Actually, there's a little bit of spasm down there. See how it spasms out?
No, it's just a disease
The
vessel.
disease vessel all the way on. A 3 balloon costs so much.
I mean, there's definitely flow. Get us at 2.5, 3.0, 2.10, guys. So we're going to have to prep the outflow vessel as well here. So we're going to go with the 2.5, 3.0, 2.10. And get us some, give me now a 6.0 long Dorado and a bunch of Serenadas. I mean, and a bunch of Illuvias. Yep, 2.5, 3.0. So what I'm going to do, David, is I'm first going to get this, ensure my outflow, and then I'm going to go ahead and take care of the inflow. So I'm going to prep I've decided to follow the sports trial and stent the entire thing. So I'm going to go ahead and now do a 6.0 Dorado for the proximal and mid vessels, and then DCB the distal and with a 5.0 impact long, and then take it from there, and then decide what we're going to do. But first, ensure our outflow first. So I'm going to go all the way down here. Okay, let me see now. So we're going to go up. Yep, 6 long. What do you got? 6 200?
100, 120, and a 150.
Give me a 150, obviously. So we're going to go up here with this just to go slightly up. There's a lot of lesions. As you can see, the AT is very diseased.
8.
Okay, 8 is fine.
600.
Yeah. Down. Okay. Okay, senor. Okay. Guys, what's he doing? Guys? Senor.
No, relax, Miss Hilda. Hilda, relax. Okay.
Go up here slowly.
Yeah. I'm gonna go 4.
200.
200.
Yeah.
2 and 4.
6 is fine.
Yeah, I'm good. 6.
Yeah, correct.
Get down. Okay. Okay, Hilda, hold it. Okay.
He feels the 2.5, yeah.
This AT is diffusely diseased. So for your
Yeah.
spree, are you planning to like line as much as you can of it, or just that, origin, or?
I think ideally, David, you're absolutely right. We should line the whole thing, but I think at this stage, I think what we do is we just go ahead and just do the esprit of the origin, and then we'll take care of it. So we're just going to take a shot here, a DSA, just to see what it looks like now. Inject. Hopefully we have straight flow to the foot. Can I have some nitrite as well?
Yeah.
Let me try one more time. It went just halfway.
No, it's fine. Let's see. No, still no flow.
Nitrite.
Still very poor flow. There it comes. Now the PT is filling.
I think just slow flow. We get nitrite and a little bit of more.
There is flow there, though. There's a perf. A wire perf. Right there. There's a wire perf there from all the manipulation. It's very soft. No, she's not reacting. Okay. All right. There's nothing going on. We'll figure that out in a second. Turn off the Angiomax for now, guys. All right. Give me now the Esprit. Give me a 3.5, 38.
3.5, 38. Open.
Yeah. Roadmap.
Yeah, roadmap.
Correct.
Roadmap, yeah. Coming.
3.5, 38, guys. So we're going to go ahead and just deploy the Esprit right there at the ostium. And then we're going to leave the stump to get to the PT at a later date. And then give me a 5.0 long DCB, guys.
Yeah. Like a 150.
Or longest you got.
Longest. No, that 01. 1.816.
So we're putting the Esprit in the distal. So audience at home, we'll shorten this down, this video a little bit. But I mean, I think all these steps are really, really important to see how we're going to manage this. So there's the Esprit going now. So I'm going to drop it right there. Agreed, Vishal? Yep.
Yeah.
Okay, let's go up now.
Going up.
So can you talk about the deployment?
Yeah, so it's a staged deployment. You put it to every 2 atmospheres incremental for 5-second break. So you go 2, count till 5 seconds. Then you go up to 4, another 5 seconds, 6, 8, and 9 is the max. You go to and keep it up for 30 seconds, and that's why it should give enough adequate time for the scaffold to deploy on itself.
Get us a 3.5 coronary post-dill balloon, guys.
Yeah, so we always like to post-dill in these cases to get the best apposition and the best outcome. So
Save that.
yeah. Another 10 seconds.
Okay, got it? Down. Go up again. So again, technique with the Esprit is very important, and what David's point is also very important. But unfortunately here, I think what we're going to do is we're just going to use one, Normally, we'd like to use more than one, but here, I think with the outflow really being an issue, I just want to secure my inflow and then decide what I'm going to do with my outflow. So we're just going to go ahead at this stage, do the aspirin there, post-dilate, and then get the 5.0 coronary balloon, and then we'll go with the Dorado. Get me the 5.0, not coronary balloon, 5.0 DCB.
Impact, yeah, DCB.
Yeah.
The length.
5.0 longest DCB. 250 is, that's the Medtronic?
But it's an 035.
It's an 035, no, I want 018.
Yeah, so 150 is the longest then. 018. Yeah, that's a 150. Okay. All right. Yeah, so.
Okay, so David, any comments so far?
No, I think this is just a
No,
great
it's good.
demonstration of complex multi-level revascularization, some of the issues that we can encounter, the ways that we can troubleshoot. But, you know, I think this is just a good demonstration of, you know, using data, using an algorithmic approach to deal with these difficult cases, even when unexpected things happen. So, you know, the audience at home really appreciates the case.
Down. Yeah, I think that, you know, I think the one thing I'm certain about is that thrombectomy devices don't have a role in these lesions. I mean, I know it's a broad statement, but I think that in our experience, we found that when we're dealing with real old clot, I think lytics, you know, we've done it, you and me, so many times together. Lytics first, followed by maybe come back the next day and then decide if you're going to use a thrombectomy. I think this kind of clot burden is good. I think the Pounce device is pretty reasonable, but it has its own limitations. Give me the 5.0 DCB now. Has its own limitations, as you know, especially in stents. We've evolved stents. We've done those kind of things. I think so. Therefore, at this stage, I really think there's still a lot of role for lytics. You know, I think that the whole idea of allowing, you know, the lysis to work and then clear out whatever fresh clot you have, and then deal with the chronic clot with, you know, whether it's going to be with a covered stent or with thrombectomy devices. I think that makes a lot of sense to me at this stage in my career.
Yeah, but let me ask you this. So remember, lysis also has its own big drawbacks. I mean,
naturally,
the lady. So are we talking about like how we do power pulse with a specific device? Like
yeah, I mean, you could do power pulse
like local TPA, or you're talking about infusion.
You definitely could. I'm not saying you can't, but I really believe that. You know, I think at this stage, you know, lytics have a huge role in what we're doing. You know, I think the more complex lesions, I think the pathophysiology with drug-coated balloons have changed everything as well. Where's the tip of the balloon now?
Right there. Right at 9.
9? Okay, go up. No, I'm talking about a top tip is about 25.
Is at 23, yeah, 24. In the
so
stent.
this is an impact balloon now. Trying to avoid stenting the pop.
It's in the stent.
Go to 10.
Wow.
12.
Yeah.
Okay, there. Okay, good. Leave it up at 12. Okay, give us another.
Relax.
Give us another, I guess, 5.0 or 6.0 impact now. 6.0 80.
Let me fluoresce.
How's that area in the groin? I mean, in the foot.
Yeah, it's soft. That's how. Exactly.
So now I'm going to use another 6.0 impact inside the Zilver, and then I'm going to balloon the prox and then put alluvias in. So let's get some alluvias. What's the longest alluvias we have, guys?
140s.
I mean, in my algorithm, I mean, alluvias and Zilvers work just equally to me. I really believe that they both are fantastic devices, but I think at this stage we really need to, you know, change the therapy since the Zilver did fail. So we're going to put an alluvia in and do it.
6 or 7 or 6?
I think 6. What was the SFA measurement, Mary? 6.
Oh, no, let me. Yeah.
That's fine. You can open that. You could get rid of the laser. We're done.
Nice.
So in this particular case, I think it was brought up previously that the Zilver kind of failed because the patient didn't really stop smoking at that time. Still had some risk factors that were not modified. So would we consider that a true failure and just switch to Alluvia, or would we still consider Zilver now that she has stopped smoking?
I mean, I agree with you. I think that when we have a choice, I mean, I think, you know, this might have failed because of smoking, might have failed because of the inflow recoil that occurred. I think vessel prep's going to play a major role here. I'm going to be very aggressive with my ballooning to ensure expansion of the alluvia. I'm going to make sure that we don't leave any dissections behind in the outflow and then take it from there. I think that's what we really have to do. So I think you're right, David. I think it's a very fair statement. But the fact is, whether it's failed because of the silver itself or it's failed because inflow or smoking, I still think it fails. So I think when we have another product to try, I think we try that product. It may not be logical, but that's my logic.
And I think just
Mag
for
up,
the
please.
audience as well, we had tried her on Xarelto 2.5 BAD as well, but she couldn't tolerate it because she had like a lot of gum
Walk
bleed
back,
and
please.
other issues as well. So just for the medical therapy arm, we did do
Okay, 1 second.
aggressive medical therapy in management. Of course, critical limb ischemia not per se, but
Go up again.
from the PAD perspective, she did get all the right medications as tolerated by her. So we did try the Xarelto 2.5
Go to
as
20,
well, just for the
please.
record.
And just to give, a fair shout out to
good.
Liberon, in addition to their separator and also the tube for the actual thrombectomy, they have a separate device called the Excipio, which is more for chronic thrombus, essentially, that you could insert that acts like a basket.
No, but I don't agree because Excipio only goes through an eight French system. It's way too soft for chronic thrombus. We've tried it multiple times. I think that's a lot of Kool-Aid that we're drinking. I think the reality is that all these devices do not do well in chronic thrombus. I think laser is fantastic. I think Rotarex works really well, but I do not believe these just thrombectomy devices separated as Excipios are really going to work really well, because we've done the Excipio, you and me, and the Excipio collapses when it hits the chronic thrombus and folds down and comes back. So I mean, it's just not there. I mean, I don't think the technology is there.
You're happy with the 6 Olivia?
Yeah, and the 6 Olivia, but now I need a Dorado.
No, we have a longer than this.
Give
me Dorado.
Give me Dorado first.
We have a 150. We should have a 150 as well. Yeah.
Give me the Dorado though.
Dorado, Tim.
No, we haven't opened the old one yet. We haven't used the old Dorado yet. So we're gonna just do a drug-coated balloon this, and we see how we have nice expansion of the DCB. Okay, then down. 2 minutes are up. We're gonna allow it to come back now.
It's right here. We got that.
We got it. So now, David, I'm not even going to give dye. I'm just going to keep working because I think that we know that we have outflow. We know we might have to give nitride. Our nurses are turned off the Angiomax at this stage because of our potential perforation. May not be. We'll figure that out. Ray's been checking on the foot constantly, so we have an idea on what's happening. So Ray will walk over, squeeze the foot on the other side just to make sure that we're not having a lump or anything in the anterior compartment near the ankle above by CSI and the marker tape. Yeah. So we're just going to go, and now we're going to go ahead and just do this Dorado and really expand this. As always, please communicate with your nurses, because the patient reacts, and then we start telling the nurses, oh my God, please do this, do that. So that's fine. Go up here. You want to change out the wire here?
Yeah, sure.
Yeah, there it goes. Okay, good. Go up now. So a little bit of what we call as Mount Sinai muscle to push that one through. So let's see, prox. Let's go. So we're going to really dilate this, guys.
Wow.
Good. Perfect length. Is it 150 or 200?
No, the Dorado.
Excellent. Now go to 20 atmospheres. So I really want to open this, guys. I have no doubt that he's going to have pain. But I do want to open this. It's fine. And it's something that we have to do at this stage because I don't want this to recoil on us.
Offload.
Good, 200. Good. Good. Thank you, Ray. Okay. Go down. So I think the recoil is not really there. We've been able to open it nicely. So now we're going to pull back and go up one more time.
It was small pump.
Yeah.
Okay, right there. Right there. Go up now. So 20 atmospheres again. 22, 26, 30. So you've got to expand this, guys. That's the key. You got to expand this. Vishal is already at Boston Scientific here, so which I think is good. And now we're going to go ahead and save that. Now we're going to get we're going to take a shot here. Do we have pressure for nitride or no?
Yeah, we do.
Systolic is only 105 though.
Let's see if the R2. Flora? I want to make sure. We're good. Yeah.
140.
It's 130?
Yeah, it's 140.
But that's with the balloon there, though.
Yeah.
That's what I'm saying. Yeah. Hold on.
So I want to make sure we have enough. Any AS or something I need to worry about here?
No.
No way.
Okay. Okay, 0. So nitride here.
Yeah.
Good.
Mm-hmm.
All right.
Not dilute. Okay. How many per cc?
50.
Okay, I'm going to give just a couple of cc's of nitride. Okay, good.
Pressure is beautiful.
Flush. Clot? No, not clot, dissection. Keep going. Mm-hmm. All right, give me some alluvias now. Actually, you want to take a photo?
Yeah.
Okay, let's flush again.
Flush?
Mm-hmm.
Okay. Flushing.
Where's nitride rate? Give me some verapamil. We have plenty of heart rate, right? Yep. Give me verapamil now. I'm going to give the 250 of verapamil. All of it. So I think medical therapy is very, very important here, guys. You know, as the pressure is a little low, we're going to get the neo ready if we need to. Okay, flush.
Yeah.
Keep flushing.
Good.
Let it come up a little bit. Keep flushing. Sure. So again, be patient with medical therapy, guys. Let it work on the microvasculature as we do these complex cases. Because now is when we're really going to make our decisions now. So heart rate is good. Pressure is a little low, which is fine. We're going to increase our flow a little bit. So maybe 7, 14, 1100. So, and then we're going to take a nice picture here. We have 100 systolic pressure, which is reasonable. All right, you fill the catheter? All right, you filled?
Yeah.
Okay. Inject. It's coming. There is
Maybe once
flow.
we fix the. I think once you fix the inflow.
Okay, I think we'll leave the pop alone. Everybody agrees?
Yeah. I think it looks good, well expanded, no real dissections. It should work out great.
There is flow. Okay.
Yeah.
All right,
Let's fix
so
the
give me the
prox.
inflow now. Give me the luvias.
Yeah. You have the 150s?
We're going to do it with the 150s.
Perfect.
So the Xarelto, you stopped because of the nosebleed?
Yeah, so she had some bleeding issue. She has hemorrhoids, so that's why I had to stop the Xarelto.
Yeah, this is going to be, because the issue here is with this kind of flow, you're going to have to worry about that.
Yeah.
You know.
I will give it another try. Like I said, we did try on her before. So maybe, so that's why she's on, I'm going to hold the aspirin part and just put on Plavix and Xarelto 2.5.
Let me distal, right?
And then go
Distal?
from there. Yeah. Sorry.
Okay, Dr. Awad, deploy the stent, please.
Sure.
So we're going to deploy 150 here.
Want to go in a little bit?
Yep. Yeah, go. You take care of that.
A little bit more? No?
That's good.
Fine.
That's good, yeah. You want to go a little more? There you
Yeah,
go.
that's it.
Go.
You remember.
Going back a little bit.
No, you're good.
You're good, actually.
You're really good.
I mean, the stent is good, yes. I'm just kidding. All right.
Okay, reasonable expansion of the alluvia here. The back thing.
Yeah, the back thing. Pull the whole thing.
Good. Okay. Now, what size do you want?
Maybe another 80 or 100? 80? No,
A little
100.
roadmap, guys. Let's do a little quick roadmap after it comes out.
Okay.
Okay, probably 150. No.
No.
100.
So if we were at 50, 100.
100. Give us 100,
Yeah,
guys.
we want to do another. 601, 100, please. Another Olivia. Yeah. Yeah.
So I think this is ensuring our inflow, and I think we have to ensure our outflow as well. So I'm going to go back down with the catheter, inject into my anterior tibial artery. So Dame, get me a vertip catheter ready with some nipride in it, nipride in the back, my nurses, so we can ensure our outflow is good. Michelle, you deploy this.
And some nipride.
Perfect. You know how to do it.
Yeah.
Watch it carefully. Top, especially when you come back a little bit. Got to come back. Yep.
Yeah,
Right there. Yep.
Right there.
I know that a lot of people use Supera for these lesions, especially in the ostium, but I know Mario Polena did the Polena trick of the popliteal access to deploy the Supera at the ostium. I think for prohibitive calcium is reasonable. In this kind of case, I think Olivia is going to do fine. You prepped it well, and then now I think you just go ahead, deploy the Olivia. Just pull back. Yeah, that's perfect. You got it. And then you're going to nail it right at the ostium. Vishal's a master at this stuff. You're doing good.
For her to.
Yeah, perfect. Okay, just one cell, which is what you need anyway. All right, now I think before we post-dilate, let's take a look.
Hold on.
What did you want to post-dilate with?
Same Dorado.
Huh?
What did you want to post-dilate with?
We're going to do it with the 6, but I just want to take a look at my outflow. So give me the catheter now, guys. The
035 Trailblazer.
Trailblazer. No, the vert tip.
Oh, okay.
We had the vert tip.
We had the word.
All right, give me a new.
Yeah, right
no, there it is.
Yeah. Flush it, please.
So I think this is a good habit to get into. Get down distal into the distal vessel, and then take a picture. Yep. So we're going to go all the way down into that distal vessel.
Yeah. That's right. Yeah.
Now I got to be careful entering the esprit. So watch, mag up on the esprit, guys. Mag up, please.
Yeah, I did. Nice.
Okay, good. Wire out. Now give me the nipride. I'm giving nipride into the foot, guys. 200 of nipride going in.
Give him flush. Flush. Right.
Flush.
You want verapamil as well?
No, I think nipride is good.
Flush, more flush. And you want a picture through it?
Yeah, I'm going to do it through here to the vert.
Get more.
More flush.
More flush. Yeah.
Keep filling those syringes.
Give him more flush.
Yeah.
Yeah. Take these.
There's no use of doing all this work without, give me a 20 cc's of syringe, without really knowing what your outflow is and then ensuring that your outflow is good. Because if your outflow is not good, all this is going to thrombose. So the idea is now, okay, you pop, you have to evaluate that a little bit better, and you definitely have to evaluate your DP. So I'm going to start distal to proximal.
Yeah.
So I'm going to look at my DP in the foot and then come back up. So, could have had microemboli, could have had a lot of things. So I've flushed it well now. Now I'm going to go down to the foot. I'm just going to concentrate on my microvasculature, make sure I'm getting perfusion that I want, and then take it easy. So let's look at the foot first. Really, really well. Okay.
Huh? No, I think we have enough. We should make a little refill some. We have punch here. Have some contrast.
So let's take a shot from here. Contrast?
Yes.
Okay. So there's going to be the DSA of the foot from the catheter. So we should be able to see everything really, really well if something is going on. So obviously not much flow. We're not very happy at all with this. So there's truly something going on in our outflow.
So at this point, we would drop TPA.
That might have been flood. No, there it comes, see? So there is flow, but very, very poor flow. There's just a lot of spasm, diffuse spasm. No clot, just spasm. Okay. And let me see what. Look at this.
I think the catheter is
There's a perf right there.
Yeah,
So that may be the reason too.
plus the catheter is occlusive too, so you don't have flush to go down, like to clear it out. This is contrast.
So now we're gonna have to deal with this. Let me pull this back a little now. Now let me inject from there. Ready? Much better flow. I think Vishal's right. Our catheter is the issue, and there's a little micro perf there that we have to deal with.
Put a wire down.
Yeah, we're gonna have to wire down, and we have to coil that.
A balloon.
So we'll do that offline. So there is flow. So we have to take care of that. Okay. Then let's go down as we deal with this. Let's look at this area here. Let's now inject from above.
Yeah.
You can let go.
Okay.
Let's inject from above. Ready?
Ready.
Much better flow. Yep. There is dissections. We're going to maybe deal with that a little bit. We'll talk about that offline. But I think that at this stage, what we're going to do is we're going to go down and coil that vessel, post dilate this, and then take it from there. I think this looks really, really good now. So the SFA flow is really, really good. So I think it's the popliteal we have to worry about, and then the perforation distal. So we're going to go with this catheter, go down and put some microcoils in. We're going to stay online, and we're going to discuss it as we do it. David, I don't know if you have to go. If you have to go, you have to go. If not, maybe you could stay with us while we do this.
I'll be here.
All right, guys.
Give me a run through.
Go ahead, take care of it. So what we're going to do is we're going to go ahead and get the coils. So get the Medtronic microcoils for me, please.
No, give me the run through.
So David, the point here is this is going to continue to bleed. It should have stopped by now, and it didn't stop. And I think what we have to do is really get down there. And I think we have to step this popliteal, guys. So I'm going to put, I mean, would you leave it, Vishal? We could leave it. I mean, it's got reasonable flow.
I don't like the dissection part of it. It looks... Wow. You think a straight up balloon tamponade would work there?
Which branch is that bleed coming from though? Like how?
Right at the S. I'm gonna see.
Are you sure though? Because there's also a small branch at 2023 that looks like it's hard to tell.
Yeah, well, that's how we're going to go down with a run through. Can I have a run through, guys?
Yeah, right here.
Go ahead, put the run through in. Okay.
I'm gonna hold the pressure. Yeah, I would you just dry a balloon tamponade to begin with to see if it? It's a very small vessel. I know coiling is definitely.
Show me both. I mean, it doesn't matter. I think it just coil makes you able to sleep.
Sure.
You know.
Might go.
Show me down.
Yeah.
Back up, please. Show me above a little. Is that the ostium? No, we're through the ostium.
Yeah, we threw the ostium. No, it's actually right at the ostium.
Take this
See,
with the
marker
acid.
1 is there, and the other is at 12. It's right there. Now you throw it.
Or ask Damien maybe. Right.
Okay, now give me the wide die, and give me a different view.
Yeah.
So you put a microcatheter down there, and
Let's
then
check one more time.
Uh-huh.
before you explore.
so what I'm going to do is I'm going to go to a view here that I can see, probably an LAO view here for the left leg. Okay. And then we're going to have to do like a father-daughter here. There it is. That's the bleed. All right. So give me a a woolly wire. I'm not a woolly wire. I'm sorry, a fielder wire roadmap.
Yeah.
I can give you a run through.
Yeah, give him the run through again.
Okay, now give me a Trailblazer, guys.
018?
No, 018, 014, or you can give me a this one. I don't. Will a Trailblazer go through here? 035, it should.
Yeah, a regular mother daughter son 018 would go,
This
or an
isn't a
014.
1.8.
The coils are.
Are the coils 014?
I have a cook and I have a box from
What about the Medtronic
Yeah,
coils?
the Medtronic coils.
private. She went downstairs to the owner.
No, where's Roman? Give me.
I had texted Roman. He's on the way.
Yeah, so. Yeah, I mean, just trying to.
Give me a fielder wire, guys.
Can I get a fielder, please?
Go to another view.
Yeah. Offered.
Okay.
Where's Damien? Ready, fielder wire. It's overlapped. Yeah.
This is overlapped.
Yeah, I think that's the only view that really. Introduce her.
Yeah, a little
That's
little ready roadmap.
Yeah, roadmap is ready. Go.
Yep, now I can see it. Okay, now give me the fielder. Make a nice curve for me. That's too much. Oh, we'll see. We'll see where it goes. We'll try. Might be enough. You're right. You could put a tamponade cloth on it and see if it stops. But I don't think. I think this is going to continue to bleed. In my opinion, it's a single vessel.
Okay.
Pressure head is really good now. I think it's going to continue to bleed. Torker.
Yeah, coming up.
Oh.
Would you do any extrinsic compression at this time with like a blood pressure cuff? Because
We
these
might
are
have
small
to.
Yeah,
compartments.
that's what I'm. Yeah. That's what I'm thinking. Sometimes an external compression also really with the angiomax off.
Plus, this is the anterior tibial compartment.
Yeah.
You know, it's very superficial. We could probably, you know.
And she is a thin lady, so it is. We can even do.
We could try.
Yeah.
And Roman's coming up with the with the coils right now.
Beautiful. So the coil themselves, they have their own microcatheter delivery, so we can just keep the wire. Perfect. All right. Oh, wow.
Just when I thought I was being smart.
Look too aggressive. But yeah. Look for another fielder, please. Don't open it.
Okay.
You have the 014 coils?
Yeah.
Beautiful. And you have the, that's an 014 delivery system, Robin? For the coil? Huh?
Sorry?
014 delivery system? Okay, what size coil? What's
Can
the
can it go through an 035 system?
I haven't tried with the tool, so
Let's-
I don't know. I can't tell you.
What size?
With the program, or you don't want to do the program.
Well, because I can't work this out. I'll lose
Hold on,
this.
one second. Here, PK. Let's try to load it.
I'll lose this.
What's the? It's not about fast. It's just the
What's going on?
prolapse.
Well, I don't know. Let's figure that out. Let's get through this first.
All right.
Uh,
Okay, let's try it. Hold on, fluoro PK? Yeah. It's going?
Mm-hmm.
Perfect. What's the
I'm
smallest?
just worried.
I have a 2.6.
You don't have one.
No one. We don't have. Okay. 2 is the smallest I've had. That's all.
No? Oh, there it is. We're going to fluoro save that.
It's not even going, Vishal.
Yeah, I think it's just so small that even an external.
I don't think you can. I don't think you can put. We can put a coil through that safely because I can't get distal.
We can just do an external. Watch.
What?
Yeah, I'm asking Damien to look for a calf cuff right now.
Watch for the wire.
Mm-hmm.
I don't have wire. Yeah. Oh, you're in.
Yeah, but I'm not in the vessel though. It's so small osteally.
Yeah.
So
I think that's something.
no. All right, we'll just do a calf cuff.
Yep, it's in the room.
I don't think there's anything we can do.
I know. Just a blood pressure cuff. Small one. And just give me a manual indiflator and give
So
me.
I think with this, we're going to take final pictures and we're going to discuss this coil. I don't think we're going to be able to get it in because if it's a microcatheter can't go distal, then we're going to have a lot of trouble trying to get this, and it's not a good spot for a covered stent. Yeah. So I think at this stage, we can try prolonged balloon tamponade and then take it from there. So Damon, give us a 3.0 balloon. We're just going to balloon tamponade it for about 15 minutes and then see if it slows down, and then we'll take it from there.
I'll just do the outside one.
Yeah, but we'll do a 3.0 as well. Internal, external we'll do. Walk this out. Yeah, you can hold pressure there. Uh-huh. So David, you can sign off, and then what we'll do is we'll continue this, and then we'll take it from there.
All right, sounds good. Thanks everybody for joining us for another very complex and interesting case from here at Mount Sinai. Our live cases are at the end of every month, every fourth Wednesday. So the next one will be Wednesday, March 25th. I just want to also give a kind reminder that our NYEVS symposium will be from September 24th to 26th this year. We expect you all to have, some very great educational symposiums. We have some new sessions up and coming that are very exciting. So we look forward to seeing you then. We'll see you next month, March 25th. Have a great day.